Good afternoon, everybody. Welcome to this breakout session, Advocating for Behavioral Health Parity in Georgia. My name is Madhuri Jha. I'm the director of the Kennedy Satcher Center for Mental Health Equity here at Morehouse School of Medicine. Our center is an entity of the Satcher Health Leadership Institute, where we're devoted to the study of advancing behavioral health equity and the larger health equity space. And we do that through research, policy, and convening leadership. Today's discussion is addressing an urgent need that has emerged during our pandemic, which includes improved access to behavioral health care and to see it as an integrated service into primary care service delivery. We are going to be doing a spotlight lens on the state of Georgia, as Georgia is in an interesting time, having just passed the Parity Act here last month. Some framing context for what parity is for our audience before we introduce our panelists is that parity is the state or condition of being equal, especially regarding status or pay. So when it comes to healthcare service delivery, parity in healthcare means equal access to all kinds of care, specifically, essentially providing everyone equitable access to physical and mental health care and not raising prices to seek support for mental health care as a secondary service. Spearheaded by our Kennedy Satcher Center co-founder, Patrick J. Kennedy, the Mental Health Parity and Addiction Equity Act in 2008 was enacted to require insurance coverage for mental health conditions, including substance use disorders, to be no more restrictive than insurance coverage for other medical conditions. When we have seen long-standing inequities in medical history of how healthcare is afforded to BIPOC communities versus white communities, parity is an important part of the equity discussion and ensuring that access to behavioral health care is equitable and equitable for all. In Georgia, state legislators have called 2022 the Year of Mental Health. And on April 4th of last month, Governor Kemp here in Georgia passed HB 1013, better known as the Mental Health Parity Act, into law. It is the first bipartisan bill to be supported by both parties here in Georgia. And some key things for this bill for our audience to know is to help frame our discussion that all health insurance plans now must cover mental health conditions as they cover physical health conditions. The bill also helps to increase mental health professionals in our service delivery process in high need areas by including student loan forgiveness programs for students studying mental health. And lastly, the new bill aims to help Georgians access affordable mental health and substance use disorder treatment for themselves and their children by ensuring that both public and private health insurance plans cover behavioral health equitably as they do physical health care. With that, it is my distinct pleasure to give the floor to our three panelists to introduce themselves and tell us a bit about how parity has influenced their work here in Georgia and the perspective that they will bring to our discussion today as we spotlight Georgia as a case study. Dr. DeJuan White, I will begin with you if you could please introduce yourself and tell us the perspective you bring to our panel.
Thank you for having me today. My name is Dr. DeJuan White. The perspective that I'm going to be bringing today is that I'm a medical director of a psychiatric emergency service at Grady Memorial Hospital, which is our safety net hospital downtown Atlanta. See a high percentage of underserved communities within the greater Atlanta area, and also lots of uninsured patients as well. In that, I also am an assistant professor at Emory University School of Medicine, Department of Psychiatry and Behavioral Sciences, and also adjunct assistant professor at Morehouse School of Medicine and their Psychiatry and Behavioral Sciences to make sure I provide education to budding psychiatrists that are doing their residency program, as well as medical students in those arenas. So I'll bring in the point of being an educator as this Parity Act is coming into providing care for underserved population here in Georgia. In addition to that, I also serve as a psychiatrist, giving direct patient care within that area within the emergency department, and also in our psychiatric observation unit, and seeing various ways that disparities are within the care that we provide based on insurance status and the ability to have that parity truly first seen in our care.
Thank you so much, and it's a pleasure to have you with us. Next up, we have Helen Robinson, one of our panelists from the Carter Center. Helen, could you please introduce yourself?
Good afternoon, everyone. I'm Helen Robinson. I'm an Associate Director for Public Policy in the Carter Center Mental Health Program. And the Carter Center is located here in Georgia. And former First Lady Rosalind Carter has been advocating for parity in insurance coverage for behavioral health care, which includes both mental health and substance use disorder care, for over 50 years now. And we here at the Carter Center lead the Georgia Parity Collaborative, which is a coalition of over 40 organizations that are working to advance parity here in Georgia through both administrative and legislative policy change. And I'm here to provide the perspective of what it's like to work in coalition to advance a policy that can impact health equity and the role of coalitions and individual advocates in state level policy change. Thank you so much for having me.
Thank you, Helen. And last but not least, we have David Lloyd from the Kennedy Forum. If you could tell us your expertise you bring to our roundtable.
Great, and thank you for having me. I'm David Lloyd, a senior policy advisor with the Kennedy Forum. We were founded by former Congressman Patrick Kennedy, who, as Madhuri mentioned, is the lead author of the Mental Health Parity Act. So I focus a lot of my efforts on enforcement of the Federal Parity Act, both at the state and federal levels. And parity is really, it's really a landmark anti-discrimination bill in mental health and addiction coverage. And it's fundamental to both access and equity. It's kind of the necessary, but not necessarily the sufficient condition. So, without that foundation, it's very hard to realize the goals that we want to realize. But it certainly, on its own doesn't solve every single, every single problem that we want to solve. But so there's kind of a broader concept of parity, that we need to work to advance beyond kind of the Federal Parity Act. But certainly Georgia has taken a major step forward. And it's really very exciting to see this done on such a bipartisan basis in such an important state, like Georgia. I think it gives a lot of momentum nationwide, to the efforts. And so really congratulate Helen, who's one of the leaders in spearheading that. So really a great, a tremendous effort.
Thank you. So we're going to get started on our questions for our panelists. To our panelists as well, if one of your colleagues say something that you would like to just chime in, and you can either raise your hand like this or use the raise hand function, I'll catch you and we'll tag you into the conversation. Dr. White, we'll start with you as a practicing physician and psychiatrist. What are some challenges you've seen with patients that our audience can understand who have either public or private insurance coverage? In general, being able to access behavioral health care. Can you help break us understand perhaps the difference between the experience of someone who might have Medicaid versus someone who has private insurance?
Sure. So there are large amounts of differences that are there, especially as they hit the emergency department and receiving care. We receive patients that are coming in to the emergency department that are either brought in by ambulance, by police officers, or self-referrals for various reasons of being within mental health crisis. In that, we find that many people in this realm are not actually being able to receive the adequate care that they need in the community based on insurance status. Definitely, there has been a difference noticed with those that have private insurance being able to access a larger breadth of physicians within the community for mental health versus those that have public insurance and trying to grapple and figure out where they are able to receive care. I will say that both populations, and especially uninsured populations, have a longer time in order to receive some of those services in the community, which lead to this further progression and worsening of their mental health conditions. And we see them there in a severe crisis. In addition to that, once they come to the emergency department and we determine that they need higher level of care, meaning that they would need to receive inpatient psychiatric care, then we see another difference there. Those that have private insurance have decreased times within our emergency department and also within our psychiatric observation units to get to another facility versus those that have public insurance just based on those that are actually taking those insurance. insurance. And of course, again, those that are uninsured have even longer period of time that are within the emergency setting, not receiving the higher level of care that they would need to receive. Also, just thinking about the medications that they are able to provide or receive. The private insurance are a bit lenient, more lenient than the public health insurances with providing various medications, especially if we talk about those that have treatment-resistant conditions like treatment-resistant depression or treatment-resistant schizophrenia, trying to get to those higher level of medications that may be a bit newer. They are not able to access them and have that overall higher quality of life that we know that they are able to, given the evidence-based treatments that are available based on one's insurance status overall.
I think you bring up so many great points. You know, I can also say too, as someone who's provided services to predominantly Medicaid undocumented patients as well, I think there's this like the secondary stigmatization that comes with also being a patient who's on Medicaid or uninsured, right? And the psychosocial distress that comes with that, and the expectation of access being limited, right? Already as a bias sometimes with treating facilities. But Helen, we'll bring you into the discussion to talk about the work that advocates play in this. You know, so tell us a bit about how advocates work together, specifically here in Georgia, to advance parity. How did we get to this bipartisan consensus? And tell us about some of the lessons you learned.
Yes, it took a very large group of organizations and individual advocates working together. I believe that the only way to be effective in policy advocacy work is to work in coalition. It is absolutely essential. So we ran a broad coalition that included not only the typical players in the mental health advocacy space, which all states would have, but also some groups that you may not necessarily immediately think of as being focused on mental health. And what we were seeing was that more and more organizations and advocates were recognizing the essential role that access to mental health care was having across the board. If you're interested in housing, if you're interested in criminal justice reform, if you're interested in physical health care access, people are starting to see that you have to center this issue of access to behavioral health care as well. And we also found, as a lesson learned, when we first started this collaborative effort, many people warned me that this is too technical. People don't want to talk about insurance. They don't want to talk about, you know, how providers get reimbursed and what's in network, you know, and we plowed ahead anyway, and we went around the state giving presentations. We would talk about parity to anyone who would listen. We really wore out those PowerPoint slides, you know, talking about parity. We had a balance, an image that showed mental health and physical health being, you know, on par with each other. And we would just show that and say, this is parity. And before you knew it, well, within 2 years, we had the media talking about this topic. And then I was really, really pleased to see that state legislators just started using the word. They would talk about it when they were being interviewed by the media. They would throw out the word parity. They would start calling out insurance companies saying, we expect you to do the right thing. And they were inspired to do that, even though parity was technical and people's eyes glaze over when you try to talk about health insurance. So I think a lesson learned is that this is a topic people are able to become very passionate about and interested in. A broad range of supporters can get behind access to mental health care. And another lesson learned, as you and David both pointed out, this is bipartisan, and it truly is. I think one of the reasons for that is because so many policymakers have lived experience with either a family member, someone in a constituent who has reached out to them with a story of their inability to get access to care for someone they care about. So there are so many legislators and other policymakers, their lives have been touched by this issue of access to mental health care. And if you can get to that with them, then really the partisanship just doesn't come into play. And with the impact of the pandemic, we just have quite an opportunity. It continues. Our window of opportunity continues here to get more policymakers talking about access to mental health care. I think the opportunity is there, and we just have to seize it as advocates all over the country.
Absolutely. And I think the pulling on the personal call that people have that are policymakers, people of influence as well, I think is a huge part of this. And David, you do this at a national level in terms of tracking parity laws state by state. To you, when you think about sort of a more national scan, what does it mean that Georgia has been able to pass this bipartisan act? You know, in the work that you think in comparing to other states, where does this take us? You know, what hope does this give us for other states that maybe could follow suit?
Yeah, well, it really helps prioritize, parity enforcement in the state by passing this, legislation. It gives, both the insurance regulator and the Medicaid agency, the kind of the tools that it needs, and frankly, the requirements that are put on them to basically prioritize this. The bill also, dedicated some staff funding for staff dedicated to enforce parity, and that's often overlooked and super important. Many states, when they put in place requirements on parity, they don't fund any staff, which then means that you basically have text in law that no one can actually take action on because there's no staff to do anything. So that's actually super important. So kind of where Georgia fits in terms of other states. So roughly about half of states now require some type of require plans to submit analyses that basically demonstrate their compliance with the Federal Parity Act. So Georgia is kind of welcome to the party among kind of almost a majority of states now. But the law also put in place really nation-leading rules relating to how plans make medical necessity determinations. So many people may have had experiences where they look at their health plan, they see something as a covered benefit, and then their provider makes a recommendation, and their health plan says, "Well, no, that's not medically necessary," and they may cite various criteria of why they aren't going to pay for it, which really makes kind of a mockery of you had health benefits. So by putting in place rules of how health plans have to make these coverage determinations, it's a bit in the weeds, but that's super important. That Georgia has put in place some requirements, and really I think it's the fourth state to do so. And honestly, the other three states were kind of probably thought of as more liberal states. So therefore, I think this is super important that Georgia has a lot on this. But Georgia has really prioritized this in an important way. And now the task that I know we'll talk a little bit more later is to make sure that the regulators are actually doing what they should be doing to take these tools and use them.
So I think it's important to sort of talk as a group what this means for advancing equity. Dr. White, I'll go to you. You both are, a facilitator of residency education programs, which are also obviously the unit director of acute care here in Atlanta in our hospital system. How do you think this act may change your work and your role in medical leadership?
I think it'll change it in multiple ways. One, helping to increase the access to care, definitely within the community. We definitely want to make sure that the people are receiving the standard of care that should be available to all Georgians here that regularly on a regular basis, and not see them have to decompensate to the point where we see them within the emergency department. In addition to that, I think that it'll also help with trying to provide decreased times within our emergency services of being able to get towards these other various higher level of care institutions in order if someone needs these inpatient psychiatric hospitalization. I think that many people have been kind of putting some of their mental health needs on the back burner, given that it has not received the appropriate compensation towards the providers. And so they had to pay out of pocket many times because many psychiatrists I know have not taken these various insurance due to lack of wanting to deal with the various insurance plans. And so I think that by having this Parity Act, I think that it'll address that by being able to access mental health care within Georgia much easier.
And if I could ask you to touch on just a little bit, Dr. White, too, because I can speak to from some of the work that we do at County Satcher Center is try and tackle sort of the breakdown of who does the service, who does our service world kind of reach most inequitably. And so for a lot of times it's people who are homeless or recently released from prison, who then on the flip side end up being what hospitals will call, I hate this phrase, but high utilizers in an emergency room. Do you think that and this is actually open for all three of you, but do you think that parity in Georgia can help alleviate some of that, right? Because I think I heard you say too how much time people spend in an emergency room. I'm also thinking about how much people just access the emergency room as their end all catch all for services because they can't get services elsewhere.
Unfortunately, I'm not sure that it will have as deep of an impact that I would especially would like for those that are uninsured and homeless. They're a very vulnerable population that don't have as many advocates or ability to navigate through the system for various reasons, whether it be financial reasons or whether it be just clear knowledge of how to kind of read through and knowledge to access these various places. Or if they're just having a severely mental health episode and not able to have that cognitive ability in order to be able to advocate for oneself in order to get various insurance that they may qualify for. And so although I think that it will assist people that already have insurance and making sure that they are accessing those services in an improved manner, I think that the uninsured population will continue to be significantly underserved.
Yeah, a great point. Helen.
I agree. I want to just add, though, that our bill did include our Medicaid care management organization. So here in Georgia, we administer Medicaid through CMOs, private insurance companies, and we would have not accepted a bill that did not include those, that only focused on private insurance. And many children, the majority of children in Georgia, are served through a CMO. And we know we have really strong anecdotal evidence that parity has been violated by our existing Medicaid CMOs, and we hope that this will certainly help with that. We've had even documented cases of parents being told to give custody of their children up to the state, so that because their CMO would not cover the behavioral health treatment that the child needed, and if custody was given up, there would be other sources of funding to pay for the treatment. So I do think this will have a major impact in that way.
And I just want to echo that. That's super important that Medicaid was included. One gap at the federal level that we're trying to close is that the Parity Act doesn't actually apply to traditional Medicaid, so fee-for-service Medicaid, which in some states, is a big population. It's less so in Georgia, but certainly, it's super important to extend coverage, to everyone. And if people don't have health insurance, the Parity Act doesn't apply to them. One other area that where I think there are very important equity considerations really relates to behavioral health emergency services, often called crisis services. And coverage, particularly in the commercial space, has generally been pretty dreadful across the country. And so, any treatment limitations that are imposed on, mobile crisis response or other behavioral health emergency services, are under the purview of the Federal Parity Act. And so we're looking in states and also federally of how do we use the Federal Parity Act's protections to basically force coverage of behavioral health emergency services, just in the same way that we would expect insurers and health plans to be covering emergency physical health services. But currently that's not happening. So that's kind of an example of where the Parity Act can be used. Granted, it isn't currently being used that way, but it's kind of the new area that many advocates are now focused on.
I think it's important to also bring in sort of the workforce perspective of this as well. We are facing the largest clinician shortage in history right now across all medical disciplines, actually, but specifically behavioral health as well. Very, very few psychiatrists, graduating psychiatrists from medical schools. But in addition to that, we just don't have enough social work, psychology, and mental health counseling professionals as well to sort of pick up some of the psychotherapy gaps that we don't see. But one of the parts of this bill too here in Georgia is to give incentives for people to enter the behavioral health clinical professions. I'm curious to hear from all three of you whether you think that'll work. What the benefits are. Dr. White, perhaps we can start with you when you're thinking about recruitment into medical school. Specifically, also, obviously, we want to focus on what it means to have clinicians of color be part of this process in the equity world. What do we need to do to make sure that that's part of something that this act sees through?
I think that the loan forgiveness and also having that incentivized is something that will definitely assist with not only having more people go into mental health services within Georgia, but also to kind of make sure that we are recruiting. I think that stigma still plays a big part overall, and that will limit some of what's going on in the full education pipeline, going from once someone enters medical school to the end. Finances are a big part of those that are getting education and all from behavioral health professionals of all disciplines. And so making sure that they're able to be compensated adequately for that and not being significant debt as they're trying to address the needs of the underserved communities here within Georgia, I think is important. And so I'm hopeful that these incentives will help to put at least a small dent within the need that we have here.
Yeah, and I'll just say, incentives are very important. Loan forgiveness, et cetera. But reimbursement is also key. That people who are thinking of going into behavioral health fields and being interested in healthcare, they often have a choice of kind of where are they going to go into physical health or mental or behavioral health, and for many people the finances are obviously a consideration. And so making sure that we have equitable reimbursement for mental health and addiction services is really key. And reimbursement rates are under the Federal Parity Act. We're trying to get both federal regulators and state regulators to enforce these provisions more, and also frankly strengthen some of the federal regulations around reimbursement. But that's a critical piece. Oftentimes kind of the one-off incentives, if they're not coupled with higher reimbursement rates, you won't have the impact that you ultimately want to have in terms of increasing the supply of providers.
I think that's a huge debate. It actually came up at a conference I was at 2 weeks ago where, community physicians, community nurses, community social workers just make historically less money than those who choose to go into private practice, specialty practice, working at private hospitals versus public hospitals. And the incentive piece of that is, yet they're carrying the burden of work in terms of the needs of those patients being complicated, complex and diagnostic treatment approach, and facing this issue of also having student loan forgiveness be part of that. So hopefully there isn't, I'll pull you in, Helen, in terms of the advocacy side. What can we do to ensure that that part of it is seen through, and what is some messaging perhaps that the audience can hear too, that they can join to have that be more equitable in terms of the type of provider as well that can benefit from this?
Yeah, so the important step for advocates to take right now is to immediately turn to implementation. Well, immediately, I say the bill becomes effective July 1st. But for all advocates, whatever state you're in, whatever you're working on, to know that we celebrate a bill's passage, but that really is not the end. The next step is to turn to implementation, to make sure that those dedicated staff are being hired, to make sure that those rules and regs are being developed at the agency level, to make sure that advocacy organizations are asking the questions, are you following through with the requirements that were set forth in this act? And I think providers play an important role in that. I mean, we would need to hear from them, just like we need to hear from consumers about, how are you seeing a difference? Does Dr. White actually see an impact of this? And in addition to the reimbursement rates from the provider perspective, they also struggle with things like prior authorization being drug on forever with, as David mentioned, those random medical necessity determinations, and I've talked to providers who have said, I went ahead and just provided treatment. I knew I was not going to get reimbursed, but this person was in desperate need. And so we want to hear from providers as this implementation begins to roll out about, are they seeing some of the adjustments? And we've made sure that in the bill, there's a transparency aspect to it as well. We're going to get to see the data that insurers submit. We're going to get a report of the complaints that are coming in from consumers into the state. And so we will, for the first time, be able to take a real look at what is actually occurring, as opposed to just relying on some of the anecdotal information and just all the experiences that we've had ourselves, trying to access care.
Sorry, I didn't realize I muted. Dr. White, any comment that you want to say too, in addition to Helen, about non-reimbursable services, basically, as you're an emergency room administrator as well, the fact that emergency rooms also eat a lot of these costs for the hospitals end up being a big burden on the hospital in the long run. Perspective you might offer the potential that Parity has to alleviate some of that, as someone who also sees the administrative capacity of these things being, compromised.
Yes, especially as the hospital does have to eat a lot of those various costs that are not incorporated. I'm hopeful that with this Parity Act that they don't have to do as much, and so be able to provide some additional services. There are definitely various things that we need to implement a bit more within various services, not only within our hospital, but also within our outpatient locations, in order to improve various mental health care, including substance abuse care. That is something that is very deficient within the Georgia community as a whole. And I think that by offsetting some of those costs with this Parity Act, we may be able to address those needs a bit more.
So we have a great question that came through from our audience. Member Leslie has commented, that the shortage is dire here in Georgia in the behavioral health space. And is curious to know from you panelists, where did HB 1013 maybe not go far enough? Was there more that you were hopeful to see? Where's the potential there? Is there things that they missed in this bill that should have been there? And David, maybe I'll start with you too, as you consider comparing Georgia to some of the other states that might have more expansive parity policies in place. That might be a good starting point for that question. It's a great question.
Sure. So among the 4 states, I referenced 4 states, the others are California, Oregon, and Illinois, that have enacted similar legislation relating to what are called generally accepted standards of care. They actually put in place some stronger standards on the medical necessity criteria that need to be used. And Georgia essentially said that those criteria need to be consistent with generally accepted standards, but didn't actually specify what criteria you had to use. So that's one area that some other states have gone further, but it's still a big step forward for Georgia, and really is one of the leaders in the country on having these rules.
Helen, any thoughts on your end that you think that this bill missed?
Yes, I just want to say that in the state of Georgia, we have a state level behavioral health commission that was formed a couple of years ago, and it was from their recommendations that this big Mental Health Parity Act was developed. That commission will continue to meet through 2025. And for any participants that are in Georgia, we all need to actively follow the work of the commission. They have said themselves they are not done, that this does not reform the system in the way that it really needs to, that there will be many more steps that need to be taken. And so advocates should stay involved in that commission work and make sure that the next report does more for workforce. I think this was a good first step for the workforce issue, but there are certainly, it's a dire need and it's an urgent need. And some of the solutions that are out there take time. It takes a long time to attract a young person into being a behavioral health provider and then getting their practice going. And, so we need some immediate relief in our state as well.
Anything from your perspective as on the provider front, Dr. White, that this bill missed that you would like to see more advocacy for?
Yeah, I just want to echo Helen's work that she talked about with the ongoing work from the commission. But I think that in order for this parity to be a success, and accountability has a big part of that, and making sure that when these complaints come up, that there are people are knowledgeable. I think that there are many that aren't quite sure what this Parity Act is or what it quite includes and how that might impact their overall care. And so I think that efforts to educate not only the public, but also the mental health providers and also primary care provider, everyone about what this means and how they may be able to navigate through making sure that we hold accountability to insurance companies for the Parity Act to be a full success will be an important step to include.
Definitely. So I think it's important to acknowledge, like, we are in an interesting policy time right now. There's several that are sitting still in Senate federally, but as well, you know, what we're talking about actively here at the County Stature Center is the launch of something like 988 being a national psych emergency line. How parity plays into access of services too, of what that looks like, I think is really important. And so we can maybe say that we are in a time of opportunity right now of pushing for policy change. So let's consider here in Georgia, the passing of parity being a starting point, and think about your ideal wish list. You know, what else do you want to see start to happen here, you know, that this bipartisan consensus can show us hopefulness for, that you think could improve behavioral health service delivery in Georgia? So maybe Helen, I'll start with you for that question, but I'd like to hear from all three of you for that.
I think we need more places where people can access care. Certainly, you know, the ER is not the ideal location, but folks just don't have a lot of options. So we need a wide range of community-based services. We need to meet people where they're at, not make them go jump through hoops to get some type of access, but have services available where they are. For example, in schools, which Georgia is leading on that school-based behavioral health issue as well. And then when you think about providers, you know, we need to expand that concept a little bit and include peers, include groups so that there can be many more providers available for people when they need it most, and that they don't have to wait. Early intervention is so important in behavioral health. Of course, it's important in physical health, but we need to understand how important it is in behavioral health. And making people wait for an appointment for 2 months, or making people wait for prior authorization for their insurance company for 2 months. These things actually cause people's health to deteriorate. It can actually lead to a crisis when the issue could have been addressed through prevention.
And I have seen that unfortunately end up fatal in some cases too, when that wait time is too long. Dr. White, what about you? Where do you see the window of opportunity here? What more would you like to see of?
Just to echo a bit of making sure that access to care increases, as well as build upon various technological advances that we've made in delivering care, especially I speak from emergency department in inner city, but especially in these rural areas of Georgia who do not have psychiatrists readily available, and they do what they can in order to make sure they address those mental health needs. I think that being able to place at least, if not additional facilities, making sure that there is a way that they can access through telehealth or some other type of means to make sure that they receive those services. And also just brainstorming a bit more on ways that we may be able to serve these uninsured patients by making sure that those that would qualify for some of these insurance plans, that they are having various advocates or ways that they can able to navigate through that to receive the services that they need. I think that would be a tremendous service that we can for a population that's very vulnerable.
Definitely. You know, David, I'll ask you to answer the same thing, but a specific thing Dr. White mentioned and Helen did. Do you think parity affords us the opportunity to have increased access to resource in the long run based on the way that you've studied this and look at it? You know, I think the resource shortage issue is one that's national in terms of the crisis. And then in rural areas, you know, we have 75% of US counties actually have a mental health clinician shortage. That's their designation. Majority of them have no access to a prescriber. That's either psychiatrist, psych nurse practitioner, or a PA. So, we talk about things like telehealth licensing compacts, where certain states are at least affording emergency procedures to have, access to at least a psychiatrist to provide medication services if they can't locate it in the state. So bringing that back to this window of opportunity, David, where is your head in terms of what parity can afford and what more should we see of?
Well, parity is critical. It has to be implemented and enforced, and that requires regulators to do their job. And if regulators don't do their job, the language in the statutory language in the law doesn't mean much, if it's not enforced. So that's where the opportunity really lies, is strong implementation of the Mental Health Parity Act in Georgia, because if that doesn't happen, then you honestly won't see much change. So that is really critical. And what the regulators look into, and they have to actually dig, is how are plans limiting treatment? What are the actual practices, and how do they meet the requirements of the Federal Parity Act? I think too often we've seen across the country very superficial kind of analysis of parity, and a lot of it's kind of been a whitewash, to be quite honest. And so unless the regulators are actually going to roll up their sleeves and really hold plans accountable, you probably won't see much change. And so I think that is super critical. But if the Parity Act is enforced, it really can be very foundational and help address a lot of these issues, and help us have a strong foundation for a system that we can build upon. If it's not enforced, then you'll have a weak foundation for that system, and you won't get the results that you ultimately want to get for all residents in Georgia.
You brought up something that made me think too, and the reason why I see parity as part of advancing equity is that after the abolition of slavery in the United States, you saw the asylum movement first and then community mental health reform, but you saw very stark differences in the way that institutions that were predominantly brown and black serving patient institutions versus white serving patient institutions were funded very, very differently. Sometimes about a sixth of the amount of funding given to one that was serving Black patients prior to integration of health services, to what someone else might receive. So I think parity also acknowledges that in terms of what equitable access is. That's the foundational premise of federal parity. We have an opportunity to see that here in the US. Any last comment? We have a minute left. If anybody wants to close and say just maybe one thing that you think is exciting, perhaps hopeful. I always like to leave the audience with that about what happened here, given the history of Georgia and as well, the history of the South in terms of being the center of where a lot of inequity has existed. Anybody want to offer anything? Maybe Helen, you, since you were really on the foreground and advocating for it.
I'll just give you a detail from the bill. We had some really strong advocates working to make sure that the bill states that when people do come and file a complaint with the state, that there should be language accessibility. And so it's an amazing thing to have that pass in Georgia. And we are excited about all of the ways that parity will help impact health equity, including the fact that there will be some recognition that people, when we educate the public, as Dr. White puts so well, educate the public about their rights, that there will actually be some thought put into making sure that the complaint portal is accessible to everyone.
Beautiful, beautiful, beautiful. Well, thank you all three of you for being champions of equity. As someone who leads in equity here at Morehouse School of Medicine, it's amazing to be in community with all three of you. You're right, insurance is not something that is necessarily, I guess, the most exciting thing, and yet it is at the foundation of how people can actually access healthcare here. So all three of you in your own roles, thank you so much. Dr. White as well for being on the front line here through COVID. We thank you for your service, of course, especially in the last 2 to 3 years. Enormous and tremendous effort here. That is it for us on this panel. Thank you to our attendees and for your questions, and we will see you all soon.